Today on the podcast, we have Dr. Daniels, who is easily one of the owner of one of the larger clinic groups we've had on the show. 13 clinics in management at We Treat Feet Podiatry, and I had a great conversation with him. So I hope you enjoy this episode. Enjoy. You have 13 clinics under management, easily biggest podcast guest we've had on the show. What's the journey? How did you end up managing this clinic group? This is probably like a long story. I'm ready for it.
All right. Well, I always preface this by saying be careful what you wish for because you may get it. And I'm absolutely the victim of that. So, 2002, I finished residency and I joined practice with a gentleman who'd been in practice for about 30 years by himself in basically a basement office. By 2004, I was making more money than he was. So, I took a pay cut to become a partner. In
Okay.
2007, I bought him out and I started acquiring practices. And it's been a steady growth to get to the point where we are now, which includes the practice, as you just mentioned. We have three outpatient ambulatory surgical facilities that are podiatry specific. We have a durable medical equipment supply portion. We have a PCR microbiological lab. We have a billing and consulting arm as we do all of that in-house as well. And we do, lots of other things that go along with the podiatry practice, such as, radiology, for example. Each one of our offices is equipped with radiology technology, so we can X-ray patients right there when we need them. And it's kind of been a long journey. I always say that if there was an expensive mistake to be made, I've made it along the way.
Mm.
And here I sit today, 20, almost 25 years later, saying, okay, yeah, that's a great question. How did I do this?
Well, yeah. Okay. Let's start with the mistakes. Like any kind of mistakes that you think would be worth bringing up on the show.
I think the one thing that seems to resonate with me as I look back on it is an expectation that people were willing to do what I am willing to do on a daily basis. I have been one of these people where my patients have always kind of come first. I remember when my son was about 3 years old, he's 22 now. When he was about 3 years old, we told him that if he, went on the potty, I would take him to Target and buy him a bike. And he went on the potty, and I got called to an emergency surgery, and he was just devastated that I couldn't take him
Mm.
that day. But and I of course took him the next day and he was fine. And now he's a mechanical engineer, so he did okay in life. But the little things where I was willing to leave and go do that case, and I knew that he would be asleep when I came home because that's kind of how it was. And I've always kind of put my patient care first, and the practice has kind of come along with that. A lot of the growth has been out of necessity, but it's just more volume than I could handle myself. Some of it is out of ego because I thought it would be great to build this large enterprise and then sell it to some private equity company for a lot of loud numbers to the left of the comma. But
We'll get back to that. We'll get back to that.
Okay, but
We'll get back to
but
that.
expecting people to have the same level of dedication to either work and or to patients has really been something that I have been wrestling with my entire career.
hmm So then, how do you hire staff? Like, how do you know that the staff you hire are going to bring the same level that you're bringing to the practice, would you say?
Well, you simply don't. I mean, we break the practice up into segments, and I only am responsible for hiring and firing physicians at this point. We have operations people, and they handle the front desk people, the administrative people, the middle management people, department heads, and those sort of things. So I don't hire and fire them. I mean, obviously, I have the ability to if we want, but I've only fired one person in my entire career, and well, that's not true. Two people in my entire career. Both times I was
Well,
forced to have to do it.
can I have more context or no? I'm curious.
One was a physician who said something that was so inappropriate to one of our
Yeah.
nurses that I won't repeat it, and we sent him home immediately. And legal said I had no choice. So if
Yeah.
your lawyer says you have no choice, what are you going to say?
It's
No,
very
you're
true. If
wrong.
the
Now,
lawyer says
now
so,
defend me when I get
go.
sued. So that's one. And then the other one got up in a meeting that I wasn't in and told everybody that they had no respect for me and I didn't know what I was doing. And
He's
of
got to
course, they all came
go. Get him
running to
out.
me. And I'm like, well, you can't have somebody, handling your money who thinks you don't know what you're doing. So
Yeah.
we had
Yeah. Of
to we
course.
had to part ways with that person too, which was a shame because it was somebody who'd been there for a couple of years. This was early in my tenure of running the whole thing. And I was fond of her and knew her family, but it just didn't work out. So, we had to do that. And then ironically, my brother, he's a restaurateur now. He is
Mhm.
7 or 8 restaurants in Florida now. But at the time, he was a general manager for an Applebee's franchisee. And, when I told him that story, he's like, "Why are you doing that?" I'm like, "Well, what do you mean, why am I doing it?" It's like, don't you have people who do that for you? I'm like, "Well, yeah, I guess. But, I kind of felt obligated because it was about me." He goes, "Don't. You hire people to do a job, let them do a job. Don't do
Hmm.
their job for them." I said, "Oh, okay." And this is a guy who hires and fires people all the time because, as he put it, waiters and waitresses can be Einstein one day and in the coma the next. So
Yeah, yeah.
he was very, very used to evaluating, managing, and dealing with people in kind of a large climate where at that point in my career, we were at 2 or 3 offices, maybe had 10 employees. So it wasn't a lot. So we're still more like a family than a company at that point. So, I learned a lesson, and to be honest with you, I haven't really fired anybody since.
Yeah, of course. I mean, a strong management team that you can delegate to, that's the core of any growing business. Okay, so you're acquiring all these clinics. Like what makes a clinic worthy of being acquired by you? Like, what do you look for? What characteristics?
So it's more on the line of how do you want to grow more than a particular clinic. So, I decided a long time ago that I thought it was easier to buy an existing business than to start a de novo one. So that included, levels of locations because we don't really see them as clinics, even though most of the ones that we bought over the years have been single doctor, who are usually at the end of a career, either staying for a short period of time or even we've had ones retire as soon as 3 months after we acquired them.
Mm,
It's easier to buy them. The equipment is in place, the charts are in place, the staff is in place. You don't have to go out and start from zero, which it can be time consuming building a patient population. We are in a, I wouldn't say competitive market. There's still not enough podiatrists where we are in the Mid-Atlantic region of the country,
hmm.
but there's enough that you can find one down the street somewhere. So, if you go somewhere, into the Midwest, into, a more rural area or down south into a more rural area, you don't have a lot of choice in physicians. And that's kind of the way it is all around. Northeast and the Mid-Atlantic are very, cramped areas. So there's about
Hmm.
400, 450 podiatrists in Maryland for about the 6.5 million people who live here. So it's a decent mix. But again, starting and then attracting patients and then building is, in my opinion, more expensive than just buying.
Yeah, and I could see that. So yeah, I'm looking at the list here of all the clinics you have. Like, and to be fair, I mean, Gettysburg is a long ways away from Baltimore. Um,
Not as far as you think.
how far is it?
60 miles. 60 miles.
Do you commute around a lot or?
Well, it's this morning I was in our Washington, D.C. office. So I spend time in our Washington, D.C. office on Mondays and then in Owings Mills the rest of the week. So, and I spend time every morning in the hospital Tuesday, Wednesday, Thursday. So, not a lot. I mean, I don't go to a lot of the offices. At points in my career, I've gone to Towson, I've gone to Eldersburg, I've gone to Dundalk. So I've been to other offices seeing patients over the course of the last, 20 years or so. But now I'm down to just the two.
Mhm. And when you acquire a clinic, like what's the playbook? Like what are you doing? Like you said, staff's there, equipment's there, but there's got to be something that's probably not there that now needs to be there. Like what is that thing?
Well, let's start with the fact that most practices either don't or more likely can't offer the services that we do. It is very expensive to run a PCR lab. It is very expensive to have a durable medical equipment side. I mean, I pay 2 people full-time salaries to chase paperwork for Medicare for diabetic shoes.
Mhm.
That's how much paperwork there is related to this. So if you're a 1 or 2 doctor practice, you can't afford 2 people who are just chasing paperwork all day. It just doesn't make sense. But when you have 10 or 12 doctors, yes, you can all of a sudden because now you got all of them prescribing diabetic shoes and you're doing not, 50 or 100 pairs of shoes a year, you're doing 1,200 pairs of shoes a year. So, it pays to do that. So we look for where is the intrinsic value in the practice because we can grab a balance sheet and a P&L and L and we can calculate whether or not this is profitable and how much we're going to have to pay somebody to work there and what the staff is and how likely the staff is to leave and what the volume is. And my whole rule of thumb is if I can break even without adding anything, then that's a clinic I want to acquire because I know I
Mm.
can bring intrinsic value by bringing in the ancillaries that we do which generate revenue for the practice. I think of practice revenue, I think a little bit differently than a lot of people. I don't think of it as do more stuff or see more patients. I think that's just, people have done that throughout time. And I think both business models are doomed to fail, especially in the current environment. The way I've always looked at it is what are they getting anyway? So if my patients are going to get things, well, why am I not the one supplying them? So we did that with our cultures. Why should I send my cultures to Quest or to LabCorp when I can do them myself and I will get paid for it? Where LabCorp and Quest has never sent me a patient, not once, ever. In 25 years, I've never got a
Well, you're
patient that I've
thinking
referred by
like you're thinking
LabCorp.
like a businessman. You're not thinking like a
Um,
doctor,
yeah, they taught me that in
which a lot
business
of doctors
school.
don't do.
As I said, they taught me that in business school.
Oh, really? Did you go to business school?
I do. I do. I have an MBA.
uh, there. Oh, really?
Yeah.
Oh, that's right. Yes, you have MBA. Okay.
Yeah, yeah,
Uh,
that's a fun story. I tell people, right around, it was about 2010. We hit $1 million in revenue for the first time, and I thought I was like the bomb. Oh, look at me, I'm generating $1 million a year. Woohoo!
I know you're
Um,
probably like,
and then I was like, well, wait a minute. I don't really know what I'm doing here. Maybe I should find out. So I went and I got a business degree, which taught me that I had absolutely no idea what I was doing. And sometimes I'm sure I do. But what it did is it taught me the vocabulary. And it's funny
mm,
because medicine is a vocabulary, business is a vocabulary. If you don't have the vocabulary, you can't speak to it. And it's all about, you can teach anybody how to treat things. Nowadays there's a lot of medicine by flowchart that goes on, and you can teach most people how to do it. The problem is, in the reason medical school is 4 years, is there's a lot of basic science that goes beyond that allows you to reason through it. And if you can just memorize the algorithm and do it, that's one thing. But if you have the reason for it, that's when you start to be able to treat the things that are falling out of the algorithm. And things fall out of the algorithm every day. Not everybody who walks in with plantar fasciitis has pinpoint tenderness on the bottom of their heel when they got out of bed in the morning. Most do, but not everybody. But understanding the mechanics of the tissue that's there and what happens allows you to be able to work through a list of differential diagnoses to come up with a correct one where, if you have a flow sheet, it doesn't hurt in the morning. Yes, no, yes. Does it get better with walking? Yes, no, yes. And you get to the diagnosis at the end of the flow sheet.
mm. So then, what was it like going to get your MBA then?
I actually really had a lot of fun with it. People laugh at me. I mentioned my brother, who's a restaurateur, who spent one semester in cooking school and couldn't hack it, and never went back. He couldn't go. He couldn't stand teaching. Couldn't stand classes, so he was done. I did it I did it at night and on weekends when I was practicing full time. But I did
Oh, that's
a cohort
crazy.
program which was all writing based. And I have a liberal arts education for my undergrad, and the one thing they teach you in a liberal arts school is how to write. So for
Yeah.
me, it was kind of fun. I just, I could do my research and I could sit down and I could write my topics, and I did very well, kind of cruising through it because I would see. It was always funny because you could always find stuff online that people had done to kind of see what they were doing and what grades they got for things. And, I would find, this section and, I'd find a 4-page paper on this. And then I'd look down and mine was 19 because just I like to be thorough. So I was just kind
Yeah.
of write, and it was very much research based. Everything I did was research based, and so that was fun. And listen, Google made a world of difference. When I
Yeah,
was
of
in school,
course.
we did Google was brand new in '96 when I graduated from college. So I went through
Yeah.
college and grad school and everything else without Google. So probably 20 years ago now, when I needed information, I just started Googling it. So
Yeah.
when I was a student, I had these large crates of file hangers with folders, and I would every time I got an article from anywhere, from a journal club, from a paper, from a drug rep, from anything, I would file these away. And these were 4 large, very heavy boxes, and they sat in my basement for years. And about 10 years ago, I realized I had looked at them in 10 years, and I finally threw them all away. But I
Yeah.
spent
My
so much
my
time
my mom's the same.
organizing and alphabetizing. Yeah,
Yeah.
organizing and alphabetizing these things, and now they're all gone. But when I realized I was Googling it and getting the articles online and not using it, I'm like, I got to get these things out of here.
Yeah. Yeah. Um, and then like this sounds like a great like you must have a decent work ethic if you're able to go to the NBA on the weekend and then run the practice. Like, do you have any secrets for work ethic or anything like coffee? What do you do to fuel
I don't,
this?
I don't really sleep, so that's part of the problem. I
We had a
don't
sleep
really get a
doctor
lot
on a
of
couple
sleep.
episodes ago.
Did you? Well, one of my fraternity brothers from college is a pulmonary care guy who now practices sleep medicine. So I mentioned
Well,
it to him once, and he says he doesn't
he
sleep
said
either. So
he said that some people actually don't need to sleep. He said that there's a very small demographic that actually just does not really need a lot of sleep, but the average person does. I mean, you might just not genetically need a lot of sleep.
Hey,
Oh,
well, then I'm kind of tired all the time, so I don't think that's quite right. But I mean, listen, 30 years ago, I read The Art of the Deal, and the president said he sleeps maybe 4 hours a night. So I don't know if that's still true or
yes,
not, but
yes.
I read it in the book.
Yeah, I love that book. I love the first couple of minutes of Art of the Deal because it's just like this. You're in the head of like an '80s businessman, and it's such a lost time. Just calls, calls, calls. Got to get on TV. Yeah, that's a good point. I mean, mentions doesn't sleep very much either in that book.
Right. So,
Boring.
the other thing is I'm exceedingly loyal and very stubborn. So I
Mhm.
don't give up ever. And that's not necessarily a good trait. Sometimes you need to leave well enough alone, and sometimes you need to know where you cut your losses. And I find that that's one of the problems that I have is I continually work the product or problem until I get to a solution. Um, I wish I could, cut and run a little bit easier sometimes. I wish I
Mhm.
had cut and run a little bit easier sometimes, but that's just not my nature.
What was COVID like for you at the clinic group?
So COVID it was a pretty harrowing and pretty miserable experience. And funny, I was on a cruise for Christmas, and when I went to ask the cruise director thing, I asked him the exact same question: "What did you do during COVID when the fleet wasn't sailing?"
Yeah.
So it kind of came out of nowhere. So at the time, I was helping to mentor my son's high school robotics team. And the previous year, we had won a banner at the World Championships, so real successful. And this is the next season. My older son's a junior now, and we start on that in January, and the first competition was in March. So we spend all this time, hours and hours building this robot, and then we get to the first competition, and we have a pretty good showing at the first competition, and then everything stopped. The stay home for 2 weeks, and everything just closed, and that was the end of robotics season. So I still went to work. There was a debate as to what was an essential business. I live in Maryland. Maryland shut down. They closed everything. My
Mm.
wife taught at home for almost, she's an elementary school teacher, taught from at home for almost a year
Mm.
after that. So, but I went to work, and initially I was in the hospital, and people were getting tons and tons and tons of pressure sores. So I was really busy. So I was in the COVID floors because we had dedicated COVID floors with precautionary things and isolation protocols and everything else. And I was in there every single day. And I'd go to the office, and there would be tumbleweed blowing down the office hallway because nobody would come. I have like four patients would come in. And it was like that probably until about uh, May or June, and then it started to empty out a little bit again. And then in December, we got vaxxed. We were the first ones to get vaxxed. And things started to kind of really open up from then, and then we went through. Ironically, I got COVID in 2022 when I was in Norway. So I spent
Mm.
2 years on COVID floors treating COVID patients. Didn't get COVID. I go to Norway. I get Norwegian COVID.
That's bizarre. I guess maybe it was a different strain. Maybe you were like immune to it, and the Norwegian was
I
right.
I honestly didn't even know I had it. My wife tested when we got home, and she was positive. She actually, it was a Monday. I went back to work, and she sends me a picture of a positive test with a text that says "Come home."
Yeah.
So I had no symptoms, and she was asymptomatic too. But we had just gotten back from Norway, and that's what we did. So, thank goodness I was asymptomatic the whole time. It took me 5 days to test negative again. I called my primary. I'm like, "What do I do?" He's like, "Yeah, symptomatic." I'm like, "Not at all." He's like, "Put a mask on and go back to work." So I did. So I did.
Yeah.
And it was fun. So COVID was real. I mean, again, from a business standpoint, it was devastating. We stayed open. We didn't furlough anybody. We didn't close any offices. We didn't, change our business model very much. We survived on PPP money like everybody else. Thank goodness for
Yeah.
the government in that sense.
Yeah.
But I saw some couple of cases of COVID toes, which was a condition. I saw a lot
I've
of
never heard
people.
of that before.
Yeah, people who got gangrenous toes from COVID.
What can you
Remember,
can you
I'm
can you
sorry.
elaborate on that? Can you like
Yeah,
I've never heard of
so
this.
at the beginning of COVID, one of the reasons everybody was dying at such a large clip is they were dying of blood clots, and we had no idea because COVID caused some weird sort of coagulopathy or clotting all over the place. Excuse me. So once they started anticoagulating people in the hospital, the death rate started to come down. Well, one of the coagulopathies that people would get is they would get COVID toes, and their toes would get embolic, and they would become gangrenous, and people would lose toes. So a handful, maybe three or four cases, not a tremendous number of them, but we have them. So that was a really big issue. And nobody knew. So once people that, and then the steroids, when steroids started becoming part of the regimen, because you don't usually give steroids to sick people, but they were started giving people steroids, and that made a big difference too. But they shut down the ORs at the hospital. So for any elective surgery was off, and any non-elective surgery needed permission from the chief to be able to take the case, which wasn't a problem for me. You got an infected diabetic foot that has to go to the OR. No one's going to say no.
Yeah.
But that was it for surgery, probably for 4 or 5 months. I didn't do any elective cases for 4 or 5 months. It was all just emergent stuff. Um,
Mm.
some of the other surgeons were dying, the ones who didn't do that sort of stuff. So um, it was rough. Yeah, I wouldn't want to go back there. I remember my father, who is in very poor health and has been for many years, even back then, got COVID early. He's a facility in Florida, nursing facility in Florida, and there were mandates here in Maryland where if you left Maryland and you came back, they could take your license. That you were not allowed to
Yeah, I
travel out of the
remember.
state.
Yeah.
So, here I am sitting there thinking, oh my goodness, my dad is going to die of COVID. And I'm also not able to go. I'm like not going to be able to go to the funeral. My dad didn't
Mm.
pass, thank goodness, but it was a really weird time. I'm on the phone with my brother who lives down there, and he's telling me what's going on. And yeah, I mean, it was a wild time. It really was.
Yeah,
But I
I
saw
think
lots
we'll
of people
always remember
die.
that.
Yeah, I saw lots of people die who shouldn't have. I saw lots of people who should have died make it. Just really not a happy time. I'm glad I don't have to wear a mask anymore, although they're telling us we should be wearing masks because all the respiratory stuff that's going around right now.
Oh, really? I didn't know
Yeah,
that.
there's big signs over the hospital, wear a mask.
Oh, really? Oh.
Yes.
Um, During COVID, telemedicine became a big thing, and there's a lot of talks about, is telemedicine still relevant? Should it be covered by insurance? Like, what's your thoughts on telemedicine? As a podiatrist, probably don't do it too much.
No, we did a
Maybe.
little bit during COVID. Mostly wound checks for me, which, was funny because, I'd have, Mr. and Mrs. Smith, and Mr. Smith would be trying to hold his phone where I could see it. And I'd be like, do you have a ruler? And they'd go get a ruler. I'm like, do you have one that has centimeters on it? The old inch wound rulers they'd have, just trying to manage those sort of things. I think it was valuable for people who really couldn't get out. I found that my telemedicine visits often devolved into just regular conversations with my patients. Just,
Yeah.
like it's like being on a podcast, just chatting for a while because again, they weren't getting out either. So everybody was kind of desperate for human connection.
Yeah.
So, that was kind of nice. People did weird things. I still have, buddies like primary cares and some medical specialties who still do telehealth. It's more convenient for patients when they don't have to actually physically touch their patients. Podiatry is a very tactile profession. We have to put our hands on things. You can't give an injection through telemedicine.
Yeah, of
You can't
course.
fix a bunion through telemedicine. You can't debride an
Yeah.
ulcer. So the core stuff that I do really was hands-on and needed to be done so. But we did do a little bit, and I did actually speak to the state society about it. I was asked to do that to kind of go through my experience with it and how it worked. And it worked fine. I didn't particularly care for it. I missed the, interaction with people, but we did do it. And I do think that there's a huge component to it. The one thing we had during COVID, which has gone away, was licensures were allowed across state lines. So I didn't have to be licensed in Maine, for example, to see one of my patients telemedicine who was up in Maine. Now
Mm-hmm.
you do. You need to be licensed in the jurisdiction where the patient's residing at that time.
Mm.
So it's a little bit of a kind of a conundrum because why is the only answer you can come up with? I mean, if you're in New York or you're in Maine and I'm sitting right here, what difference does it make that I'm not in Maine, but I am in New York, for example? I don't know. I mean, these
Well,
are
kind of exposes it
questions
a
that,
little bit. The fact they got rid of it briefly in a moment of crisis. So,
yeah. So lots of things happened and some things stuck around and some things went away. And, I think we all learned to deal with things in a little bit of a different light based on just sheer necessity. But I hope that's the only one I have to be part of during my lifetime.
one thing I thought was super interesting when I looked into your clinic group, We Treat Feed, you're a sponsor of the Baltimore Orioles.
We have been, yes, which has been
That's
fun.
what's up with that? What's the history of that?
No, I mean, again, listen, for the right amount of money, you too can be a sponsor of the Baltimore Orioles. Um, we signed on. We did two things with the Orioles. We had digital rights and a digital page takeover. So twice a year, there was the We Treat Feet was all over the Orioles website. And we did We Treat Feet upgrade your seat. So they take two people from the nosebleeds and move them down on the first baseline and put them on the big, jumbotron and have them wave and say thank you and those sort of things. So it was just some cross promotional things. They had a corporate partners box, so I got to go to a bunch of Orioles games
Yeah,
sitting in the
you're just
box.
supporting the local team, right? Like
Pretty
it's
much.
like fun. It's fun. Yeah, that's
It
awesome.
is, and it was fun, and I really liked the Orioles people, the business people. It was really funny because they really are segmented and fragmented. Like the business people have no idea what the baseball people are doing. I assume the baseball people have no idea what they're doing. Yeah, so I'll
I
go
think
almost
that's such a
anytime.
great accomplishment to be able to sponsor like your local team. I think that's kind of when you know you've made it a little bit. Definitely.
Yeah, I'll know when I made it when I retire and don't have to work anymore.
Yeah. Well, okay. So
Someday,
I always
maybe.
here's something I always ask doctors about. So there's always this big thing about private equity buying clinics. You've got a couple clinics under management. Like, what is your thoughts on the private equitization of clinics?
So it's a more complicated question than that because I think at the core of that question, what you really need to be looking at is there a place in the modern world for for-profit medicine? So I work in for-profit medicine. I am not a not-for-profit company. A lot of the medical systems that are not for profit only have the not for profit arm, and they have a for profit arm. Usually that's the one that employs the physicians. Um, and you look at the big companies, United Healthcare, or Cigna or Aetna or Blue Cross, and they pay their executives millions of dollars. So is that something that's ethical? Should your healthcare be based on the value of a dollar? I mean, again, you're talking about a much larger, socioeconomic uh, construct than I think is intended here. The truth of the matter is I think it depends on who is in the management group of the equity group and what their actual intentions are. Because I've dealt with private equity a lot, both as buy side and sell side consultants, and I can tell you that every single one I've ever spoken to has been waiting to buy, build, and sell to the next guy. And eventually, someone gets stuck without a seat when the music stops. And
Mhm.
there always just seems to be this opinion that there's somebody else, somebody else, somebody else. So, when the economy went bad during COVID, all the PE activity basically stopped. Um, I was working with groups and they just went on hold for 8 months or 10 months. Then they started back, and now there's a lot of interest again, and there's people forming around. There is an economy of scale argument to be made for all of this. I make that in my own business. Well, why do you have so much? Well, because again, I can afford two people full time to do the work for 10 or 12 doctors, whereas if I was by myself, there's no way I could afford one person to do that work. So, there is that sort of argument to be made. Um, I I have not found that things are a lot better. I do know some people who are in equity owned groups who are very happy with it. They do take away the administrative burden and make practitioners' lives easier for someone like me who's spending full time practicing and full time running a business. But by the same token is you always have to be super careful because everybody wants to play doctor, and Dr. Google's right there, and it is tempting to start saying, well, why aren't you doing this? And the answer is because it's not medically necessary. And equity guys like, well, what does that have to do with it? So you
Mhm.
run into some problems. So,
Those are
I
very
do think
dangerous.
it is, and there's a conflict that can happen there. And, you do have less than ethical people on both sides, not just the equity guys, physicians who, just try to, find stuff to do for the purposes of billing. As I said, again, we don't do that. What we try to do is find what they're getting anyway and provide it. It's a different way of looking at, providing services to patients. If they're not going to get it, we're not going to give it to them. But if they were going to get it anyway, you know, might as well be us who provides the service. And that way we can control, the dispensing, the quality, we have better control over what the patient does from a utilization standpoint or a compliance standpoint. It just makes a lot of sense when you think of it that way. But right now, equity is still going and, deals are getting done. And I think, bar a larger economic conversation, I think you're going to see a huge amount of private equity activity in 26.
Yes, yes, and that's kind of a major theme on this podcast, especially because we're like an AI company. Doctors are so nervous to get AI involved in the practice, at least doctors without MBAs. But
Not me.
private equity, they're ready. They're like, let's go. So,
Efficiencies. So we started using it's probably been about 18 months now, ambient AI technology for patient visits. So
mhm.
I utilize it basically for everything. Some of my doctors don't use it at all. Some of them use it for some things. I have found that there was a lot of material in my notes that I just thought of as passive conversations that were medical advice that should have been in my notes all along that increased the level of complexity of the things that I'm doing. And it took AI to show me that, to really understand the value of what I was bringing people because, we would have diabetic foot care visits and we would talk about diabetes and the need for better A1C control and diet and exercise. And that would be nowhere in my note previously, where now it's forefront in my note. And I am providing those services to patients, but I never really thought of it that way before. So AI has helped me kind of consolidate what I've been doing all along into words that therefore improve my documentation and in theory then improve the patient care we're providing. So I'm
Yeah,
I'm a big proponent of that. Same thing with, billing and posting. I sneak peek writing an article for a publication where I'm arguing that the doctor-patient relationship is now dead, and it's now the doctor EHR patient relationship
yes,
that has now
yes,
replaced
yes.
it. And the saving grace in that relationship can possibly be AI because EHR has taken the largest chunk of attention in the room. It's no longer the doctor, it's no longer the patient. The
Yeah.
EHR is where everyone's attention is focused. So I've been toying around with that for a couple of weeks now as I've been trying to kind of polish that up and get it ready to submit.
Well,
Um,
yeah. I mean, scribes
so,
definitely help with that.
I mean, it depends on what you mean scribes. So they're human scribes, and human scribes, I think, are a huge waste of time because if you've ever seen notes by human scribes, all they're really doing is pushing the buttons that doctors would push by themselves. So it's
Mhm,
just, they're for lack of a better term, the monkey's monkey.
mhm.
They're not adding any value. They're just allowing the clinician to do less, which allows them to do more other stuff. Whether or not that's value or not, I think that's a different conversation. But the truth of the matter is it didn't improve documentation. AI improves documentation.
Yeah.
So the question now becomes is okay, so if AI improves documentation and AI there improves efficiency and billing, who should supply the AI to the practice? Should the physician be paying for the AI or should the insurance company be giving the AI out to the patient? So the insurance company is getting proper documentation and coding support to their level.
Well, they don't want that.
Do they? I mean,
Well,
again, do they? Right now, you're
imagine you're
suffering from
United.
CPT creep.
Imagine you're
Yeah.
United and you build your super AI, like your denials AI. And all these doctors, they go, I don't need AI. Next thing you know, you get your denial rate up. I mean, that's the ultimate goal, right?
Well, it depends. You got to think of it this way. And this is the one thing that people neglect. If they have to reprocess claims, it costs them money. Reprocessing is not something they do. I mean, we've always talked about them denying claims for the purposes of a float to hold on to the money to collect more interest to, boost their bottom line. But every time they process a claim, it costs money. And, if we have to send it three, four, five times, sure, we're losing money too, but so are they. It's an inefficient system. So if there was a system that could be sitting there that could, randomize the data in a way that the insurance company couldn't understand which patient it was, yet alone ensure, documentation completeness, fairness, and coding compliance, that might save them
Yeah.
money too. So, it's one of those things where if you look at it, depending on the study, somewhere between 8 to 17 cents of every dollar Medicare spends is what goes to physicians. The
Yeah.
rest of it, 80 plus cents goes to everything else. So it's really not physicians that are the problem here. The physicians are actually the ones who just, eat the chunk of it. Last
Yeah.
year we had a 2.8% Medicare fee reduction. This year we got a 2.5% increase, except it wasn't 2.5% across the board. It was 2.5% of two of the three items that compile an RVU unit. So it's really about 2.1% when you break it down. And inflation was 3% this year. I mean, they're arguing that's a good thing. So, look at how we're falling behind. I mean, RVUs were originally came about in I think in the 80s, and they're about 33, $34 for an RVU now. But if they were indexed
Mhm.
for inflation, they'd be $70.
Mhm.
So, that's how far doctors have fallen behind in reimbursement since the 80s. And my question to you is well, where's the money going? The money's
I
there.
don't
It's still
know.
coming in. These companies make record profits. They're taking in record premiums. Premiums go up every year. I'm sure your health insurance premium went up this year.
So
Everybody's premium goes up. Where's the money going?
the other answer.
Administrative overhead. There's way too much of it. I don't know if there's enough to make a difference, but there's way too much of it. I think the amount the executives are being paid is grossly ridiculous. I can't imagine what the CEO of a hospital or United Healthcare or whatnot needs, tens of millions of dollars in salary. And I understand the argument. It's not the money, it's what the money says. But still, those are patients those are dollars that are not being spent on patient care. And if you watch NBC Nightly News every week or whatever, they have this cost of denial series they've been running now for months where they find somebody with a unique condition that insurance denied and miraculously gets improved when NBC gets involved. This
Yeah.
week, it was
Yeah.
about a prosthetic foot. It was a college young woman in Texas who I missed the part of how she lost her foot, but the prosthetic foot was $7,500, and insurance didn't want to pay for it. And it wasn't, at the end of the day, I paid very close attention. Everybody in my family was hysterical because I like walked away from everybody who stood in front of the television and watched the story. But it was one that was a cosmetically appearing foot. It wasn't just, a peg. If you've ever seen a
Mhm.
baloney prosthetic, they're just a little, foot shaped piece of plastic or carbon
Yeah.
fiber or something. No, it was a very, very eloquent, like the toenails were painted. It was her tone, flesh tone. It was very, very nice. And I understand the argument. I mean, you're talking about a 22-year-old, young lady who, doesn't have a foot and wants something to walk around on. But, you know, is that the best use, or should we be spending that money giving Keytruda to cancer patients, to save their
Mhm.
lives? There's life preserving and life affirming, which is more important.
Yes.
And where do you
Yeah.
draw the line? I'm not an ethicist, so I can't answer that question, but I could sure ask it.
Yeah. But thank you so much, Dr. Daniels. It was one of my favorite episodes, definitely.
Oh, it's been a pleasure. Thank you for having me.